All right. What's going on, everybody? Happy Tuesday. Let's see if we can get some likes or comments here. Just making sure our audio sounds okay. Looks like we're coming through on X. If I can get some likes or something on any of these, let me know audio sounds okay. Thumbs up. Sweet. I'm doing very well. Thank you. Appreciate it. I need to get more into basketball and hockey lately right now. Right now that like the NFL is kind of dying down, no games this weekend. I need to start paying more attention to hockey and to basketball. This is usually about the time that I start paying a little bit more time to paying more attention to those. Yeah, staying warm, staying well. I'm gonna switch. I don't really like the way that this looks here. Back to live mode. If I can switch the color on something here. There we go. Let's just keep that nice dark black. Drake May's shoulder. Yeah, we will talk about Drake May's shoulder. Absolutely, we'll talk about Drake May's shoulder. Let's start there. No, I'm not gonna watch the Pro Bowl. I'm not gonna watch the Pro Bowl. If there's some skills competition stuff that's maybe interesting, I might watch some of that, but I'm not gonna be watching the flag football game. All right, let's talk real quick about Drake Maye, and then I want to spend kind of the majority of the time here going through some more stuff with this 49ers injury data stuff. I had a lot of fun this past weekend playing around with the data set that I put together, playing around with Claude, using it for things. Clean that up off the screen. And I want to take some time, like if people have questions they want me to put in here to look back at like any old historic NFL injury trends, let me know. We'll run it and see what the data set shows. I went through the Pro Football Reference pages and scraped like all of the injury reports going back to 2009 and put it on a spreadsheet. Took a bunch of time to try to clean through it, but now I've got a pretty good spreadsheet put together with literally everything that showed up on the NFL injury reports back to 2009 for every team. And it's really fascinating the questions that you can ask and go through to try to get some sense of relationships between things, to try to get some sense of the data. One thing in particular that we are definitely going to take a look at here. Let me pull up something. Let's see. I've got too many tabs open. Let's see if this was it. Somebody posted a really interesting picture from Reddit that was about the changes in, yeah, here we go. All right, we're going to throw this on the screen here. So this was posted, hope there's nothing like private on my browser. This was something super interesting. Someone on the 49ers Reddit mapped out the history of their strength and conditioning staff since Kyle Shanahan took over, right? Because everybody's trying to figure out, like, is there something going on? What's the deal with all these 49ers injuries? And so this was fascinating. Basically, somebody mapped out, like, what's changed with all of the different strength conditioning personnel every year since Shanahan's been there. And so what I did real quick before the stream started was I put in the data, my spreadsheet, and then gave it that picture and said like, hey, here's the changes in all of the 49ers medical staff. And it actually, I haven't like dove into this too quickly yet, but it gave an actual maybe interesting role when different people were taking over here and going through things. But so we'll get to that in a minute. If you have other questions like, oh, what's the trend in, XYZ team, XYZ injury, that sort of thing. I've got all those graphics here too, right? Where I went through for my video I put up last week, and we can go through some of those charts and look at some of that data in terms of, most injured teams, least injured teams. So we can absolutely step into some of that. But I've got too many things open here. All right. So let's talk a little bit about Drake Maye. I've seen a couple questions about Drake Maye so far. No, I'm not. Like, to just get to the bottom line on Drake Maye, I'm not too worried about Drake Maye's shoulder. This whole thing got started, right? Like, Dr. David Chow, Pro Football Doc on X, SIC, Sports Injury Central, I think is his kind of company website, whatever you want to call it. I'm not sure how they would describe it. But so, like, to his credit, he pointed out some good things, some things that I didn't see, even though I was watching the game. And essentially, right, here was the play where Drake Maye's scrambling. And you can see as he got up, let's go back to kind of when he first landed. So here he is, right? He's running out to the side. As he goes here, he gets tackled. He kind of lands on his butt at first, and then arm gets tucked up underneath him. If you look at it, a little bit faster, slower replay here from head on. This was the play where everybody's all concerned and saying like Drake Maye has some, bad shoulder injury. So he comes down, lands, elbow catches the majority of the impact. Right arm gets kind of tucked up underneath of him here. Let's make that a little bit smaller so everybody can see. And then what we see after he gets up is he kind of look right. He's reaching at his right shoulder pad here. And that was Dr. Chow's first suspicion that like, oh, maybe he injured something with his shoulder. What I'm not too worried about here is if you pay attention to what happens with his shoulder pad. So his shoulder pad gets pulled up, right? And we see guys all the time after they get up and their shoulder pad gets messed up, they're fiddling with it to try to put it back down and put it back in place. And he actually adjusts both of his shoulder pads when he first gets up. So if you take a look right here, right, he's plays with the right one a little bit and then real subtle there, you see him grab for the left one. So he's actually adjusting both of his shoulder pads. The moment that I will say like, maybe I could justify and validate before he throws that flea flicker pass, you can see how he's kind of moving that right shoulder around, right? So he kind of, he's moving it around a little bit. So yeah, sure, maybe he felt something in his shoulder. What you've got to remember, like at this point of the season, and I think their coach did a really good job of describing this. Like at this point of the season, all of these players are dealing with pain in some way. Like they're all having pain. They're all having some sort of shoulder pain, knee pain, hip pain, back soreness, etc. They're all having some degree of pain, but that doesn't mean that they're injured. And that distinction between somebody who has just pain and somebody who's got a distinct injury is, I think, really important to understand. Do I doubt that Drake Maye had some shoulder pain? I'm sure he had some shoulder pain, right? He gets tackled, he lands hard on his shoulder, it's going to hurt. But just because it hurt in the moment doesn't mean that his shoulder is hurt, if that makes sense. Those are two different scenarios. There's a difference between you just have some pain and your shoulder like is truly injured. Like there's a rotator cuff tear, there's a labrum tear, there's a true like damaged structure that is injured long-term that's going to cause you issues. And so I think that his shoulder hurt during the game, but I don't think his shoulder got to the point where he injured his shoulder during the game. And I certainly don't have any reason to suspect that this is going to cause issue with him for the Super Bowl. I mean, he continued to play really well, right? You're not going to throw that flea flicker play, that pass, if your shoulder is injured. The stiff arm that he threw later in the game when he ran out for that first down and that third down conversion, I don't have any concern about it. So no, just summary with Drake Maye. You can go watch. I did a full video on it last night. I don't have any concern. Is his shoulder hurt? Yeah, his shoulder's probably hurt. Like everybody's hurt at this point on both of those teams, but I don't think that reaches the point of saying like he is clearly injured. That has a lot more implication with it. So that's my thoughts on Drake Maye. No, I am not worried about his shoulder. Also, they've got 2 weeks, right? Like 2 weeks is a very long time to, get some treatment on stuff if there is some like bumps and bruises, etc. So yeah. Yep, the video I did on the 49ers with the EMF stuff. Eventually we'll figure out how to make some of these look better. Conspiracy, yeah, not too strong of a word. Yeah, I don't know. How do you think the 49ers looking at the substation plays out with regards to any investigation? Here's the tricky part of this. Based on like these questions, there's no way to definitively prove one way or the other. I don't think there's any way to definitively prove it. And so everybody who is a proponent of this theory or this hypothesis is probably the right way to describe it, that the 49ers are having injury problems because of or in part due to this substation and the EMF. Like you can't prove them wrong. There's no good enough study that you could do that would justify any of their concerns and would make them say, oh, okay, sounds good. Like, we'll move on. The same way that you can't do a study that is going to reliably prove that it does cause problems. I think the first thing that I think you probably have to do is just like go around to different stadiums and different practice facilities and measure what the EMF exposure is. But there's so much just background EMF everywhere. And then you not only would have to do that to like see, okay, one facility versus another facility, one team versus another team, is there variation there or not? You've got to look at it at the time of day. You have to like clearly map out the exposure levels, the environmental data in terms of what there. But then you also have to like follow each of those individual players around, and you've got to measure what their EMF exposure is on like a day-to-day basis, because the amount of time that they're at the facility during the year compared to the amount of time that they're elsewhere, just like living their life, the facility time is minuscule compared to the rest of their year. And those other environmental exposure situations are going to have just as much potential effect on their body as when they're at the facility. And so it would be an absolute mess. Like, it would be such a convoluted, challenging, difficult thing to try to get any strong sense of like reliable data out of it, that I don't think anything is going to come of it. Like, if you ask, yeah, exactly. Like, there's like substations like this all over the place. And what's going to happen is they're going to talk to a bunch of experts. They're going to talk to a bunch of respected academic PhDs, doctors, etc. And they're probably all going to come back and say like, no, there's no sound evidence to suggest that this is true. What I was trying to do is I looked through all of my different graphics with my analysis that I put up over this past weekend, was trying to say like, number one, do they even have an injury problem? Because everybody assumes that they're like the number one most injured team by far, and they're not. Like, no matter how you slice and dice it, if you look at, you know, like cumulative games missed, right, in the last 15 years, they're like 7th, 8th in the NFL. This measure here was trying to kind of pool it all together and do like a composite score, taking into account total games missed, total number of injuries, and then average games missed per injury going back just 10 years, right? So trying to think, well, the substation was upgraded in 2014, so like maybe we should start there. And they're number 4. So it's not like they're crazy outliers in all of these different metrics. And so the whole fundamental problem of like, oh my gosh, they're these crazy outliers, I don't think they are. Like, I don't think they're statistical outliers. The only thing that I did find going through all this data, they are true statistical outliers when it comes to the number of knee injuries of all things. Like if you look at knee injuries going back to, I think, 2009, when I have the data going back, they are true like statistical outliers for knee injuries. It's very clear. If you go back, I think, to 2015, just the last 10 years, I think knee and calf injuries, they're statistical outliers. But I even went through, so like with this data set, I can go through and I can even say like, okay, is it a Kyle Shanahan problem? So I can go back and pull the offensive players from the Washington years when Shanahan was the offensive coordinator at Washington. And I can say, okay, are the injuries for like the Washington offensive players while Shanahan was there higher than offensive injuries in the rest of the league? Did that effect then continue when he was at San Francisco? So you can look at all these things, and the data doesn't really like tease out. The one thing that I think is some, you know, argument specifically against the whole substation theory is you can look at, basically I looked at the era when the facility was upgraded, 2014 to 2016. How do they compare to the rest of the league average? And then how do they compare during the Shanahan era, 2017 to present? And it's clearly so much worse during the Shanahan era. Now, some people will try to argue that that's like a cumulative effect. There's no way that you're going to tease out between the two of those, right, over time. And a lot of those guys weren't necessarily even there the whole time. And then even looking at like players that were with other teams that then went to San Francisco versus players that were at San Francisco and then left, there's no worsening that happens when you go to San Francisco. There's no improvement that happens when you leave San Francisco. It's a complete wash in that regard. So I don't think the data is there. And hopefully they look at some of this data and they say, well, like, goodness, do we even have an issue? And I think they're going to find that they don't actually have an issue. And so unless there's such strong pushback from like the NFL Players Association, from the league, like players aren't going to like threaten to leave or not sign there. Like you actually look at Christian McCaffrey, and Christian McCaffrey's injury numbers are better since he's gotten to San Francisco than they were when he was at Carolina. So you can't even look at that instance where he's freaking out. He's like talking to all these people that I would say are maybe a little bit on the fringe of like traditional medicine. And he's doing better, like in San Francisco. He's missing fewer games per season, I believe, compared to when he was in Carolina. So, like, it doesn't make sense. There's just, in my opinion, no strong data there to back up that claim. Jacob Pertle's back. Not sure. I'll take a look and see what I can find here with it. That's not one that I'm familiar with recently. Let's kind of see what we can learn about here. Giannis, man, Giannis, it's like the second time he's injured his calf, just literally like running up and down the court. And so I don't know what to make of it. I'm always skeptical too whenever stuff is happening like around trade timelines and, you know, like what's really going on. I don't doubt that Giannis is injured. It's hard to like understand the full extent and severity whenever there's so many other factors at play. Jakob, yeah, it just looks like back strain. I mean, there's no reason to be worried about anything else. Presumably they've you know, MRI'd him. I don't see anything different going on with Jakob Pertl. Yeah, I think they've even like with the substation stuff, they've looked at like large population studies to try and determine like is there any risk, and I don't think they find anything there either. Like there was some study that like really high levels of continuous EMF exposure might have some increase in leukemia, I think was like the one actual like, okay, maybe there's something there. And that's what got it labeled as like a possible carcinogen or whatever it is. But there's literally been nothing else. And so I just don't like, you're not going to convince the city of San Francisco to move their substation. And you're not going to like completely uproot your training facilities for something that the data doesn't even hold up. So anyways. All right, let's see. Any other questions? Genicular RFA for chronic pain. Yeah, I think they work really well. I don't do radio frequency. So genicular nerves are the nerves that go through to innervate the knee joint. And one of the treatments for people with like chronic knee pain, osteoarthritis, is to ablate those genicular nerve branches so that you don't have the pain signals coming back from the joint. You can do it in a lot of different joints. There are other joints like hip, shoulder, where you can do a similar thing to try to ablate the nerve that carries the pain signal back. So yeah, I think they work really well. I don't personally do them. It's a different kind of set of procedural training than what I do. I'll do injections for these to try to help the pain, but that's it. All right. Well, we don't have as many questions coming in the chat here, which is okay. So let's go over to our community page and let's talk about some of that. We're gonna get rid of that guy. Let's see here. All right, community questions. Sorry. Yes, Santa Clara. My bad. I've been to San Francisco once. Don't have much desire to go back, to be honest. So yes, Santa Clara. Sorry. Thank you for clarifying. The city of Santa Clara, I don't think is going to move their substation. All right. Let's take a look through some of these my posts. All right. Let's zoom in a little bit here so we can see this more clearly. All right, top question. Talk about runner's knee and knee pain. Very good question. We see this a lot. So runner's knee is, we also call it patellofemoral pain syndrome. Patellofemoral pain syndrome is like the proper technical medical term. But runner's knee is another term you'll hear for it. Let me get rid of some of our connective tissue stuff, and we're going to go look at our hip. So here we go. So looking straight on, so runner's knee, right? If anybody ever has been diagnosed runner's knee, patellofemoral pain syndrome, here's essentially what we think is happening. There's kind of a lot of different mechanisms and theory behind why people feel pain, but it's basically pain coming from the patellofemoral joint. So the joint space behind your patella is causing pain. Now, Typically in like true patellofemoral pain syndrome, there's no big cartilage defects or damage on the backside of your patella because your patella has cartilage behind it. It's like the most loaded part of your knee joint whenever you're bending, squatting, etc. And so normal cartilage, normal structure, but you have a lot of pain behind your knee. Typically, it's really bad going up and down stairs, often can cause some popping, clicking, cracking, crepitus, that sort of stuff. The main theory, and I think the easiest way to describe it to patients, it's really like a load problem. Either sometimes not enough load, sometimes too much load, more often than not, like not properly managed load through this joint. The biomechanic way that I think about it, if you go all the way up to the hip, and this is the reason why runners get it a lot. So whenever you're running, jumping, squatting, etc., ideally the line that the force is all being transmitted through your patella is staying like very stable, straight up and down, upright. When people have weak glute muscles, so gluteus minimus medius up at the pelvis, whenever you're running, there's a time in your stance where you're just on one leg. And so when you're on one leg during your running, going up and down stairs, etc., your glute muscles up at your hips are trying to fire to keep your pelvis stable. So if you've heard of like a Trendelenburg sign or Trendelenburg gait, Trendelenburg gait is whenever your pelvis drops because you have a lot of weakness on these muscles on the side of your hip, either from a muscle, a tendon tear, nerve injury, and your glutes aren't firing to pull your pelvis back upright. And so if your glute muscles are really weak, that tends to make your pelvis drop, and you can get this downstream effect where your knee wants to go inward a little bit, and that can alter the loading pattern behind your patella. And so a lot of the ways that we try to rehab and treat it is to work on those strength deficiencies and those biomechanic deficiencies. Sometimes that's like a lot of hip dominant PT. Sometimes it's more quad dominant PT. I personally am not convinced that you'll read a lot about like VMO stretch or VMO strengthening. The VMO is the vastus medialis obliquus that kind of sits right here on the inside of the knee. And the thought is like, well, if that's, stronger, then it can pull your kneecap back in proper alignment. The data is suspect, in my opinion, that you can selectively strengthen your VMO. The literature on like quad exercise versus glute exercise, there doesn't seem to be any difference. It's whatever people can tolerate. So that's runner's knee. Runner's knee is this patellofemoral pain, often due to muscle weaknesses and imbalance in that kinetic chain of the lower limb. Think of it as a load management problem, and you got to get stronger. A lot of runners get it because a lot of runners neglect their glutes and have very weak glutes. Probably one of the most common things that I see in young folks with knee pain, to be honest. Kind of that middle-aged teenager, middle-aged 20s, with knee pain, very, very commonly is patellofemoral pain syndrome / runner's knee. All right. Other questions on here. When athletes get contusions, are there any specific treatments done on the area besides the Rice method to break down the collection of blood and speed up recovery? Could you also talk about the risk management assessment? You don't mitigate compensating injury. That's a loaded question. Let's answer the first part of this. So the Rice method, rest, ice, compression, elevation. Essentially, this Rice method was developed as a catchy little acronym for how to initially rehab musculoskeletal injuries, right? So think of an ankle sprain. You sprain your ankle's all swollen. You hear about, Rice principles: rest it, ice it, compress it, elevate it. There's now like a whole push for the opposite direction. So if you get online and you read about like, hey, is it bad to ice my sprained ankle? In fact, like the guy who originally developed this Rice method has now come out and said like, oh, it's completely wrong. Icing is terrible. You should not do any sort of icing. And it's kind of controversial. I'm much more on the favor of like ice your stinking thing that hurts. There's a couple reasons why. The literature that's come out to try to suggest that ice is bad for acute injuries is based on some animal models, some animal studies that showed like suppression of the soft tissue healing response with cold temperature. So if you're icing a structure, you're actually like suppressing that inflammatory reaction, and that inflammatory reaction is part of what eventually starts the healing process. So do I think you need to ice your ankle for the ankle ligament to heal? No. What I think you need to ice your ankle for is for, hey buddy, 1 second. We're going to quick pause, everybody. What is it, buddy?
I can't go to sleep. My nose.
Okay. 1 second. Can you go find mommy and I'll be in there in a minute, okay? Sorry. My son just walked in here out of bed. So essentially, like, the where was I? Sorry, that really threw me off. um, so I would much rather somebody like ice their painful swollen ankle to help get pain under control, because then once you can get pain under control, then like you can more appropriately begin your rehab. And I think beginning your rehab, like starting your range of motion, starting to facilitate some exercise, is what I think has the most benefit for your recovery. And so I would rather somebody just like ice their painful joints so that they can get their joint moving better to get some of the swelling out to encourage movement, because I think the early movement is more important than worrying about some animal models showing suppression of healing pathways. So, but yeah, this is like the basic stuff you can do on your own. Like medical staffs will do some other stuff like stim, ultrasound to deliver deeper heat to help with pain, dry needling. There's some like lymphatic massage things, taping that people will say helps to improve or like decrease swelling in soft tissues. So yeah, there are definitely other things that people can do to try to help support some of that. All right, Josh Allen's foot procedure. So we have not heard anything updated about Josh Allen, to be honest. I don't know, right? We haven't seen anything. There's something that was going around on X that was speculating on what it might be, and so if we take a look, let's go back and look at that here. um, so this account, Thigh Doctor, does a lot of stuff with Bengals content. Essentially was speculating that like potentially it might be a Jones fracture. So a Jones fracture is a fracture at the base of the fifth metatarsal bone in the foot. The thought was like maybe there's some extra padding that we could see on his shoe, and that would make sense if you were trying to put some extra padding on your shoe for a Jones fracture. This would not be like a minor procedure. This would be like a full-on surgery to put like a screw or something in there. And I think if he was going to have it done, we'd have heard about it already. So I don't know. To me, I don't think this is like a Jones fracture. I think a Jones fracture is too significant of an injury for what we heard about with like a potential small procedure. Yeah, appreciate it. You're welcome for answering questions. Absolutely. Still keeping an eye on the chat. So anything comes up in the chat, we will absolutely try to get to that. I'm not seeing as many questions come in there, but that is okay. It was a while ago. How did Joe Burrow come back from turf toe surgery in 10 weeks when the normal recovery time is 3 to 6 months? So the normal recovery time after the surgery is probably just average 3 months, like 12 weeks. And you got to remember that term average, right? And so there's a lot of variability there, right? That means if your average is 12 months, that means there's going to be some that come back at maybe like 10 or 11. There's going to be some that come back at like 14, 15. And so averages are averages because there's people on both ends of the spectrum. There's going to be some that come back sooner. There's going to be some that come back later. I think it's a handful of things. I think it means number one, he had a good surgeon, right? Surgeon did a great job. You know, no complications after the surgery. Everything goes according to schedule once the surgery is finished. Probably the most important thing then is he had a good rehabilitation team. He had a great rehab team, physical therapists, athletic trainers, strength conditioning, etc., to help facilitate his rehab in the quickest, fastest, most optimal way. That's probably because that's also going to be like the bulk of the time commitment is going to be with his rehab team. And also then just him, right? His genetics. There's a lot of variability in terms of how different players heal, how their body recovers, how quickly they're able to recover from these different things, etc. I was impressed. I didn't think we'd see him back. I did not think we would see him come back as quickly as he did. So I thought that was really good. Patrick, you need to go to bed, buddy, okay? I understand. Dad will be in there a little bit, okay? Go find Mama, okay, please? I know. Go find Mama, okay? I'm sorry, guys. He's a cutie. That's my 3.5-year-old who keeps coming in here thinking that I'm gonna go do something with him. Let me see here. Give me 1 second. All right. Evan Mobley, second calf injury. Let's see. What can we answer here? Talk about with Evan Mobley. Oh, yeah, another calf strain. Yeah, I still like. I still am not convinced that this whole calf strain leading to Achilles injuries things is legit. I think a properly managed calf strain um, should do just fine and should not have any increased chance of Achilles injuries. Yeah, Patrick, he just wants to talk sports medicine. Exactly. You probably couldn't see it off screen. My 3.5-year-old son kept opening the door to come in here to wanna join our conversation, which is okay. It makes it fun. All right. So let's see what else we got in here. Jalen Green situation is very unique. He's had the exact same injury take him out for weeks, and then returns, plays the full game just fine, then gets hurt the next with the same injury. Yeah. So Jalen Green is dealing with a hamstring injury, and I think everybody. I always kind of joke about like hamstring injuries are tricky, right? Everybody describes a hamstring as a tricky injury, and I think there's a pretty good reason explanation why they can be so difficult. Really, any soft tissue muscle strain is like this, but hamstrings for some reason seem to be one of the main ones. This was actually good to see. This was today, I believe. Yeah, January 27th. We see him warming up a little bit before the game, so that's really nice. These muscle injuries feel better before the tissue is done healing. And so if you think about like the healing process, the recovery process for tissue injuries, soft tissue injuries, the remodeling, right? Whenever you just like tear a muscle, eventually your body has to remodel all that to as normal muscle as it can. But that process takes months. And so in the first like days after you have a muscle tear, everything just kind of bleeds, right? There's blood in there, there's all these cells, macrophages that go in there. Everything is just trying to like fill in the gap, fill in the defect. Your body then starts the healing process by laying down just rough scar tissue. This scar tissue is, it's collagen, but it's not like good, helpful collagen. It's kind of just like rough, like spackling, right? That you're just trying to throw in the drywall crack to roughly cover it up and get things filled in. What then starts to happen is your body comes in and it takes that rough scar tissue and it like breaks it down and tries to remodel it into like muscle tissue. But that remodeling process takes a really long time. Like for an ankle sprain, that remodeling process to get those ligament fibers to like remodel appropriately takes months. And your pain is much better before that process is completed. And so what often happens with these muscle injuries that kind of re-aggravate and have issues is people feel really good before they're fully healed. And so they feel good, they want to get back out there, they're ready to go, but they're not fully healed. They go out and they make things worse. And then you can just kind of start this spiral of injuring that same location. And so that's why, trying to have good objective measures of like, it's not just how you feel, but it's how you function. How's your strength? How's your range of motion? How's all that sort of stuff is important. But you got to remember that I think the key lesson there with the hamstring injury recurrence is that they feel better before they're truly better. Now that doesn't mean everybody's going to get re-injured, but that's what you've got to think about. Yeah, the coaching style with the 49ers. Yeah, I think Sean Payton's coaching style, more frequently longer durations. Yeah, this was interesting. So actually, if you think about this was a comment about Sean Payton having really difficult practices back when he was in New Orleans. And if we look at, let's see, I put it in here somewhere. So kind of an aggregate going back the last 10 years, New Orleans number 2, right, in the list in terms of overall severity. Now, Peyton wasn't like, I think Peyton left in like what, 2017, 2018. And so this doesn't capture that all perfectly. If you go further back, like 2010 to 2025, and you just look at total games missed, I think this is, yeah. So total games missed. New Orleans, the Saints were number 5 on the list. If you look at just like total, these are soft tissue injuries. So things that are listed as like calf strain, quad strain, thigh, hamstring. They were better, right? They were down all the way kind of below or pretty much right at NFL average. So yeah, there might be something there with Sean Payton's coaching style. Hard to say. There's so many variables. Perfect example. So this whole injury like tracking stuff and this whole database and like these terrible years, if you look at what happened, so for example, 2014 was a particularly bad year for the 49ers. They lost a ton of games due to injury. 2014, number 3 overall in the league in terms of games lost due to injury. But if we go back and you actually look at what happened that season, so if you go back in, this is what I'm talking about with where you can get this data. Now you've got to know how to go through and actually kind of scrape it and find it. But let's go back 2014. We can do it quicker up here. 2014 injuries. And then you go to injury report, and this is what they show you. So you can go through this. This is basically what I did. I went through this for every team. But look at all these. Like Navarro Bowman, the entire year was on the player unable to perform list. They had at least 3 players that I found. So I believe Brandon Thomas was one who tore his ACL in college. The 49ers drafted him with an ACL tear, and he missed the whole season. So he shows up on their injury report as a loss of 16, 17 games, but his injury had absolutely nothing to do with the 49ers. He injured it in college. The same Keith Reeser was another one who had an ACL tear, I believe, before he ever even was drafted. But the 49ers drafted him in like the 7th round. And so, like, right there's 32 games lost that are counting in all these statistics that people are using to track all this that you would argue have absolutely nothing to do with the 49ers. Coaching staff, facilities, anything. The injury happened before the player was even there. And so one thing I've thought about trying to go and do is look at like how many of these injuries are rookies. But I think I got the point across in terms of just how it's not as clear cut of a problem. But that same issue could be there for all these other teams, right? I mean, if you went through and were able to actually do that, you'd probably find a lot of difference in the numbers because some teams will get worse, some teams will get better, etc. Bo Nix. Yeah, I don't know. I don't know why they don't just come out and tell us. Like, giving us small bits of information almost make it worse. Like when Sean Payton comes out and says, oh, like the doctor said it was eventually going to happen no matter what. Like, what is that supposed to mean? Like, does that mean he had something going on that was like harmful to play through and that they knew about? I have no idea. I still put my money on like a medial malleolus fracture. Like maybe there was a stress injury there or something. So I don't know. That just made things way more confusing and weird. By them saying like, oh, well, it was bound to happen eventually. Like that somehow makes it better. I think that just makes the whole situation stranger and harder to talk about. All right. Herniated cervical disc. I don't treat spine stuff, I'll be honest. Youth sports injuries. What is the most important thing you would recommend to coaches or parents to know in the case where someone might not medically trained around to help? So someone who's not medically trained to like be around to help. My brain just goes to like the worst case scenario. So if you guys remember what happened with Damar Hamlin, the commotio cordis, right, where you get like struck in the chest and then you get the impact like right at the appropriate time of the EKG, the heart rhythm cycle, which causes you to go into cardiac arrest. A lot of the cases you'll see about this happen in Little League when somebody gets hit in the chest with a pitch or something like that, and they're like walking down to first base, and as they get halfway to first base, they collapse. It's usually a delay, right? We saw with Hamlin, he stood up and then he collapsed. And so always, if someone collapses, is unconscious, just call 911 and check their pulse. If they don't have a pulse, start pushing on their chest. Don't worry about mouth to mouth. Don't worry about all that. If someone passes out, call 911. Try to check for a pulse. If you don't think they have a pulse, you're like worst case scenario, you break some ribs, but you're not going to otherwise hurt them by trying to do CPR if you think they don't have a pulse or in cardiac arrest. So a lot of people too, like sometimes someone will go into cardiac arrest and like their muscles will jerk like they're having a seizure, and sometimes that delays timeline to get to something like CPR. So always somebody who goes down, no matter what the situation, check a pulse. Thanks for joining. Ask any questions away. We will get to them here in the chat. Another youth sports thing that honestly I was thinking when I first read this question, for overuse injuries and like how many hours of your sport is too many to be doing. A good rule of thumb is hours per week, no more than your age. So a 7-year-old should not be doing more than 7 hours a week of their sport. Which actually seems pretty reasonable, right? Like if you're 10 years old, 10 hours of gymnastics, right? Maybe like a few practices throughout the week for 2 hours. That's 6 hours. Competition on the weekend, another 2 to 4 hours. Like that's pretty reasonable. And so if you're a parent, number of hours per week, no more than age in years. I tell patients this: if we start seeing a lot of overuse injuries, they come in and they're like 9 years old and they're doing 25 hours of cheer or gymnastics a week. I'm like, it's too many. It's too much. They're going to get hurt. It's setting yourself up. So that's a good quick rule of thumb to look at. All right, tore my ACL meniscus during a football game last year. Didn't know I was hurt until the next week. I was wondering how common that is. Yeah, more common than you would think. I, in probably the last year, have seen 3, 4 teenagers, college kids, who tore their ACL like a month before I saw them, or like 2, 3 weeks before I saw them. And they just have been able to compensate in a way that they don't really notice it. It's not totally unheard of. It confuses us because we're like, well, this happened a month ago. Like, surely if your ACL was torn, you'd be in here by now. But it always gets me. You go there and you go and you test their ACL, and it's like, whoa, wait a minute, wasn't expecting that. And you go back and kind of talk to them more, look at them walk again, and pieces kind of start to fall into place. Remember, the muscles are trying to help support your ACL. So some people have really good muscle control, where when their ACL is deficient, they just have good muscle support to help compensate really well. Some people don't swell up a lot. They're not doing the demand of sports that'll, really prompt them to realize that something's going on. Usually what happens is they come in and they just say, like, not so much pain, but they just don't feel right. Like the knee just doesn't feel right. And that's usually the clue to look further. So yeah, sorry that happened to you. Not too uncommon though. Happens more often than you would think. All right. Let's see what else. Cam Ward, AC joint injury, didn't require surgery. Can you explain the long-term effects of this injury and why you would or wouldn't get the surgery? I can. And I'm going to show a picture of, a lot of people are probably going to guess who I'm going to get the picture of. Chargers player, one and only Keenan Allen. Let's see. So this is a good example of what happens if you have a serious AC injury that you don't have surgery for, right? You end up with these big pointy bumps on your shoulder. So this is basically what happens with a chronic AC sprain, a chronic AC separation. What you got to remember though is, like, not all AC separations are created equal. And so if we go up and we look at the AC joint up here where the right collarbone meets the tip of the shoulder blade, so your type 1, right? Grade 1, 2, 3 doesn't really apply the best because we use something called the Rockwood classification, type 1, 2, 3, 4, 5. Type 1 is like a little bit of just sprain of that ligament, but x-rays look fine. It's stable. You're not going to end up with a Keenan Allen shoulder. Type 2, you start to get a little bit more widening. The clavicle starts to elevate. Type 3, the clavicle is like sitting way up here. That's unstable. The challenge is though, like, just because it's unstable in a type 3 doesn't mean you need surgery for it. And so oftentimes it is just a cosmetic thing. Like, people are able to compensate really, really well with these chronic type 3s where their collarbone's just kind of floating up here. And so players who are compensating okay, don't want to undergo a surgery, right? That stuff can always happen with the surgery. If you're doing fine, there's not like a structural stability reason you have to get it fixed. A lot of times people might get it fixed or addressed after they retire or come out of the league. So that's what we don't know with Cam Ward. We don't know what his type was. We don't know if it was like a unstable one where the clavicle's elevated or if it was a more straightforward one. Oh, here we go. Okay. Other questions? Will people ever see Bo Nix's x-ray? I don't think so. I don't think we're ever going to see it. Maybe someday he'll share it. I don't know why. Like, what's the harm? Anyways, I don't know. That's me, somebody who wants to see it because I'm curious and enjoy making content about stuff. But no, I don't think we will get to see it. EMF update. Yeah, we talked about that. Aspinall's eye. Yeah, it sounds like he had another eye surgery to go in there, right? We talked about with his eye injury, that muscle wasn't like spinning right to help rotate and control the eyeball. Had an injection. It sounded like maybe that injection didn't do what it needed to do, and so it sounded like he was having surgery to go in there and try to like free up that space so that his eye could rotate appropriately. Queasy, seeing explaining some of these injuries. No, honestly, at this point, not really. Just, you see so much other stuff in medical school and residency and training that watching something on the internet doesn't really bother me that much. What bothers me more is hearing stuff, like hearing sometimes on the broadcast, like you'll hear like the player screaming or like crying and being really emotional. Um, that's hard. Like that's honestly the hardest part of seeing all these because like you feel that, right? Like I've been there in the moment when somebody's injured and like crying in pain and fear and all that. Let's see. Bread and butter. Spiral fracture just means the spiral like twists around the bone. That's a spiral fracture. No, I have no concern about Sam Darnold's oblique injury. You're not going to need surgery either. You don't do surgery for oblique injuries. So no, it'll be something that'll do just fine in the off season. Yeah, we talked about the predisposed thing. I really, again, don't know what that means. Nothing I've seen about CJ Stroud. Um, yes, I will do some Winter Olympics coverage if we get it. We will definitely be paying attention and following along. Let's see. Alex Zverev, tennis player with type 1 diabetes. Really cool. Basically, it's exercise influences your insulin. So Alexander Zverev, I can never say his name. I assume that's who they're talking about. High level tennis player, has type 1 diabetes, and still manages to compete at a high level. Really, really, really impressive. Exercise influences how your body releases insulin and uses insulin. And so when you're type 1 diabetic, your body does not produce insulin, and so you have to inject it exogenously and monitor your blood sugar. And exercise has huge swings that it can cause in your blood sugar levels. So this is really tricky. It's really tricky to do. It means he's got a good team around him. It means he's consistent because consistency is really key. So yeah, it's always cool. I'm always really impressed to see high level athletes that manage diabetes. This is the kind of thing that like you've got endocrinologists, like a sports medicine doc is not managing his diabetes. Like he's got an endocrinologist that's helping manage all this. Yeah, I need to the injury data stuff. I'll try to figure some of that out. I don't want to just like put a massive Excel file up yet. I'm trying to figure out some other ways to go through and fill in some more of the detail before I just put something up there. Yeah, NIL and college sports. Let's get to this first. Concern level on Malik Neighbors. Yeah, nothing yet. It's too soon, I think, to have a strong like concern or fear about him. His surgery, I think, was a little bit more delayed. He probably had like an MCL sprain that had to heal. What is so hard to predict with these players is you don't know how they're going to do with their rehab, right? Like you can have the best surgeon in the world, but if they don't really dedicate themselves and do really well with their rehab and their physical therapy, terrible outcome. And so to a point, like a lot of it is on the athlete. And without knowing, like we all assume that these high level athletes like take really good care of their bodies and are like really dedicated and this and that, but right, we've seen plenty of examples of that's not true for some of these guys. So that's the unknown that's hard to predict, is like how hard are they going to hit their rehab, how attentive are they going to be to their rehab, and we have no way of knowing, right? I would assume good, but we never know in some of these things that have complications or things go wrong or whatever. So handful more here. We're actually almost to about an hour. Let's see. Yeah, so Achilles injuries, actually, like I looked at it in the NFL, Achilles injuries are going down. Like people can argue it, but according to that injury report data, um, Achilles injuries are decreasing. So, right, I looked at it because I was curious about COVID timeframes and was trying to see like, does COVID have any influence on any of that? Now, granted, like this isn't capturing who got vaccinations and whatnot, but post COVID, there are fewer Achilles injuries than there were pre COVID. It's pretty clear. And just overall in the league, Achilles injuries are downtrending. Like this was updated 2025. Let's see, I ran this back like a few weeks ago. So this like 2025 might actually have been the fewest Achilles ruptures we've had in a season in 15 years. So all this stuff about like Achilles injuries, like skyrocketing and this and that, like the data like says no. The data says it's not. But I think the issue is we've seen more impactful Achilles injuries, right? When it happens to Aaron Rodgers, it happens to Micah Parsons, it happens to Daniel Jones, it happens to all these high-level players, it feels more impactful. When it happens to Jason Tatum and Tyreke Halliburton, it's like, holy cow, this is the worst thing ever. When 5 of them happen to the 8th guy on the bench, nobody cares. And so I think it's just more that it's happened to impactful players than it is that it's happened to more players. Because in the NFL, it's down. NFL Achilles injuries are going down, if you can believe this injury report data, which I think is the best we have to go off of. All right. Let's see. I think that is pretty much everything. All right. Girlfriend wants to be an ophthalmologist. When athletes get a significant eye injury, other than a bad poke in the eye, can the med team do anything depending on injury, or do you go to the specialist? Yeah, it just depends. Usually, like, the medical staff there is doing the initial evaluation and say, like, hey, do you need to go in and see a medical specialist? And so that we're doing the initial, like, you know, are your eyes tracking okay? Where's your pain? What does it visually look like? We're not really doing anything to fix it or treat it, because a lot of this stuff, a lot of these minor, like corneal abrasions, right? Unless they're specific cases that need antibiotics, like, you're not really doing much with that. So, like, we'd prescribe antibiotics in those cases if needed. If someone's got, you know, floaters and their vision is changing and we think they've got a retinal detachment, like, yeah, absolutely, we're just going to send them into a specialist. So we're not like treating a lot of eye injuries. We're just evaluating for potential eye injuries. And then if they need to be seen, we send them in to be seen. Yeah, to go to a specialist. I'm not managing somebody's, you know, like what Aspinall is doing. That's not a sports medicine doctor that's managing that. That's an ophthalmologist or an optometrist, depending on the situation that's managing it. All right. Any last questions? Going once, going twice. Anything else? Nope. All right. Sweet. Very good. All right, everybody. Thank you as always. Appreciate it. Appreciate the couple new members who joined. Go check out the latest videos on the channel. Really enjoy it. Again, thank you very much, everybody, for participating. And y'all have a great week. See ya.